And next we move on to the next session. It's on toxic optic neuropathy. I invite Dr. Dahlia Krishna. She is a senior medical retina specialist from Shrikant Eye Hospital, Calicut.
Thank you, Dr. Soumya, for that opportunity. Good afternoon, all. So I would be sharing my insights on toxic optic neuropathy. So as the name suggests, toxic optic neuropathy refers to visual impairment due to optic nerve damage caused by a toxin, which may be a drug. So it typically presents with bilateral, painless, progressive, usually symmetrical visual loss, which changes in color vision. Here, the vision loss progresses over months rather than days. And on examination, there is no RAPD. The optic disc may be normal or swollen. Optic disc pallor appears later with central or centrocecal scotoma. So there are numerous drugs and toxins associated with optic neuropathy. Notable among them, the ATT first-line drugs, ethambutol and isoniazid, linezolid used for MDR tuberculosis, amiodarone, many anti-cancer drugs and immunomodulators are also implicated. Methanol causes an acute toxic optic neuropathy as an exception. The risk for toxic optic neuropathy increases when the drugs are used in high dose or prolonged duration in patients with renal and liver disease, old age, low weight, malnutrition, diabetes, substance use, and occupational exposure for a long period. Different substances affect the optic nerve in different ways, but the common pathway seems to be the mitochondrial injury with the imbalance of intracellular and extracellular free radical homeostasis. So thus, the toxic optic neuropathy is an acquired mitochondrial optic neuropathy similar to Leber's, as ma'am said. So for the diagnosis of optic neuropathy, the clinical history usually indicates the possible etiology. So toxic optic neuropathy, which has a slower course, has to be differentiated from compressive, infiltrative, nutritional, and hereditary optic neuropathy. To work up a case of toxic optic neuropathy, a detailed history, including the drug history and the toxin exposure and the risk factors I mentioned before, are very important. Ocular examination should have vision, color vision, contrast sensitivity, pupil, fundus examination, visual field testing, and OCT examination for RNFL and GCL thickness. Investigations. VEP is very important to confirm the optic neuropathy, and neuroimaging to rule out compressive optic nerve compression lesions. Blood tests, including liver and renal function test, rule out, and also syphilis serology is important. Specific tests for the specific toxins are required. Coming to ethambutol optic neuropathy, we are all seeing increased incidence of ethambutol optic neuropathy following the revised guidelines of RNTCP program, which allows for daily dose and longer duration of ethambutol use and fixed dose combinations where the number of tablets prescribed is based on the weight band of the patient. So studies have shown that the ethambutol related optic neuropathy increases with increasing dosage. So the patients with low birth weight, kidney disease, older age are at now higher risk for ethambutol optic neuropathy. And the toxicity typically appears between 3 to 5 months of age, but may present early or later. Presenting a case of ethambutol optic neuropathy where a 73-year-old male patient came with complaints of difficulty in reading for the past 2 weeks, on ATT for tuberculous pleural effusion for the past 4 months. On examination, pinhole visual acuity was around 612 in both eyes with defective color vision and decreased contrast sensitivity. No RAPD with nuclear cataract. Fundus was normal, but the perimeter revealed grossly decreased sensitivity with lot of defects. VEP was done, which showed decreased amplitude of waves, which was more severe in the left side. MRI brain with orbit was done, which is normal. So the chest physician was advised to stop ethambutol. So after stopping ethambutol, his visual field and the acuity improved over the next 3 months. But the visual acuity and the field improvement is very variable after stopping ethambutol, as seen in some of these patients. This is a 64-year-old man who came with ethambutol toxicity. After the stopping ethambutol, initially his vision actually deteriorated in the first 2 to 3 months and then improved over the next 7 months. In this 27-year-old male doctor who came, again the same deterioration the first 1 month and very slow improvement over the next 2 years with some residual defects even after 2 years in the left eye. In this renal patient, over 6 months follow-up, not much of improvement. So to highlight the increasing incidence of ethambutol optic neuropathy, what are we doing? So Indian Neuro-Ophthalmic Society organized a meeting of leading experts in the field of neuro-ophthalmology, pulmonary medicine and pediatrics to create a consensus on possible advisory and examination schedule to pick up early toxicity. The consensus was on clinical presentation diagnosis, screening and primary prevention with special recommendations to physicians and ophthalmologists, treatment and reporting of adequate reporting of ethambutol toxicity. Coming to isoniazid optic neuropathy, which presents with bilateral optic disc swelling and bitemporal hemianopic scotoma. So in a patient on ATT, if the vision loss is progressing even after stopping ethambutol, INH has to be stopped. Next, coming to linezolid optic neuropathy, which is seen in patients on multi-drug resistant tuberculosis. Here, it is recommended that frequent visual function monitoring should be done if the linezolid is being given for more than 28 days. Sharing one of my cases, where a 51-year-old male patient with history of defective vision of 1 month duration, known diabetic, on treatment for multi-drug resistant tuberculosis past 18 months, was on linezolid for the past 6 months with other second-line drugs. INH and ethambutol was stopped 9 months back. So after his visual acuity, coloration and visual fields were found abnormal, linezolid was stopped, showed a good improvement over the 4 months period with the baseline visual acuity achieved after 4 months. Coming to amiodarone optic neuropathy, presents with very slowly progressing binocular loss of vision. Very important point is you have prolonged disc swelling, and these patients on amiodarone therapy also have the same risk factors as the patients of non-arthritic AUN, so needs to be differentiated. And the points in favor of amiodarone is it's an insidious onset, as non-arthritic AUN is the acute unilateral visual loss as presented before. The resolution of disc edema in NAN is over weeks, whereas in amiodarone, it is protracted for months, it may stay, and NAN has the crowded disc in the other eye. Coming to methanol toxic optic neuropathy, which is one of the causes for acute optic neuropathy, not an insidious loss, usually found in cases with ingestion of adulterate alcohol contaminated with hooch. The visual loss usually is seen after 12 to 24 hours. Diagnosis confirmed with the serum methanol levels, and treatment of methanol poisoning is advised. Before I summarize, I want to share this case of an 89-year-old doctor brought by doctor's son, not able to read newspapers since past 1 month, diabetic, hypertensive and cardiac patient on treatment. On examination, his visual acuity was 6/60 in the right eye, 4/60 in the left eye. Pupils were reacting. Fundus showed moderate NPDR in both eyes. Confrontation fields were not showing any hemianopia. OCT macula was done, which showed a mild DME in the left eye. So, not finding a clue, I sent for a neurological consultation with neuroimaging to rule out any cortical cause for slow visual deterioration. 2 weeks later, I got a call from one of my beloved teachers saying that the doctor's son had forgotten to tell me that he was in ATD for the past 4 months. So a thorough history is so crucial to making a diagnosis. So to summarize, treatment of toxic optic neuropathy does not always yield fruitful results. Prevention is the key with baseline evaluation before starting treatment. Early detection can salvage vision. Asking for specific drug history in all cases of insidious visual loss, very important. Stopping the offending agent is the only treatment option, and proper follow-up and testing can help toxicity early. Thank you. I take this opportunity to invite you all to Ignite 2025, which will be held in Kochi on January 4th and 5th. Thank you.
Thank you, Dr. Dahlia, for that wonderful talk covering all the toxic neuropathies and highlighting the importance of histories. History and clinical examination still holds good in, especially in neurology and neuroophthalmology. I think we cannot give up. Definitely imaging and other high-tech investigations do give us a nudge for diagnosis, but definitely history and clinical examination has a very big role in coming to a